If you think blood tests just give us a signal of some little diseases like fever, then you are totally wrong because some tests are not reported normal. They shocked everyone who see them. And patient conditions some may look simple, but in reality they have deep meanings that can directly connect it with your kidney. And in today's video, we will show you 8 blood test results that signal kidney damage, so you are in the right place. Don't go without watching this video completely to know better about you. Number 8. High serum creatinine levels. Well, one must look the uncomfortable truth straight on. Creatinine only rises when something downstream isn't doing its job properly. This compound forms every day as muscles burn energy. Nothing unusual, nothing alarming by itself. The problem starts when it lingers. Healthy kidneys remove creatinine efficiently, clearing it from circulation before it ever becomes noticeable. When blood tests show elevated levels, it means waste is staying in the bloodstream longer than intended. That delay matters. Creatinine is useful because it reflects real-time filtration pressure. If the kidneys slow down, even slightly, creatinine responds. However, it's influenced by muscle mass, hydration, age, medications, and supplements, which is why doctors never treat one reading as gospel. Persistent elevation across multiple tests is the real signal. That consistency tells a clearer story. Filtration efficiency is slipping. The thing that makes it dangerous isn't pain or symptoms, because early on there usually aren't any. Instead, excess waste circulates quietly, stressing blood vessels, increasing cardiovascular strain, and interfering with bone and mineral balance. The body tolerates this for a while, which creates the illusion that everything is fine. Creatinine itself isn't toxic, it's evidence. Evidence that nephrons are underperforming and that clearance capacity is shrinking. When addressed early, this slowdown can often be stabilized. When ignored, scarring accumulates and functional units are lost permanently. Elevated creatinine isn't a crisis call. It's an early notice that the filtration workload is no longer being handled cleanly. Number 7. Low estimated glomerular filtration rate. Imagine checking a long-term forecast rather than today's weather. That's how eGFR functions. It doesn't show a single moment. It estimates overall kidney performance by combining creatinine with age, sex, and body size to calculate how much blood gets filtered each minute. In healthy adults, that number stays comfortably high. When it drops below 60 and remains there for 3 months or more, chronic kidney disease is no longer theoretical, it's defined. It doesn't just ask, is waste building up? It asks, how much filtration capacity remains? That makes it invaluable for tracking progression. Early declines rarely produce symptoms. Instead, subtle shifts begin internally. Acid balance drifts, electrolyte strain regulation, and metabolic waste clearance slow. Short-term drops can happen from dehydration, infection, or medication effects. Those often rebound. A slow, steady downward slope tells a different story. It reflects structural nephron loss and reduced functional reserve. Aging lowers eGFR slightly, but it does not cause a persistent decline. That distinction prevents dangerous assumptions. Clinicians rely on repeat measurements to confirm trends and avoid misclassification. When eGFR continues falling, it becomes a predictive tool, not just a diagnostic one. It signals how close the kidneys are to compensation failure, long before swelling, fatigue, or appetite loss ever appear. eGFR doesn't warn loudly. It warns early with math instead of symptoms. Number 6. High blood urea nitrogen, BUN, levels. All right, this is where confusion sneaks in for a lot of people, because BUN sounds scarier than it really is, until you understand what it's pointing at. Blood urea nitrogen comes from urea, a waste product created when your body breaks down protein. Your liver makes it, your bloodstream carries it, and your kidneys are supposed to flush it out. When BUN levels rise, it simply means too much urea is hanging around. The real question is why? Kidney problems are an obvious suspect. Chronic kidney disease, acute kidney injury, or reduced blood flow to the kidneys, seen in shock or heart failure, can all slow urea clearance. But kidneys aren't always the villain. Dehydration is one of the most common causes. Less fluid in the bloodstream concentrates urea, making BUN spike even when the kidney structure is intact. Diet plays a role too. High-protein eating, protein supplements, trauma, burns, or internal bleeding in the digestive tract can all flood the system with extra urea. Certain medications, especially NSAIDs and ACE inhibitors, can interfere with kidney blood flow and raise BUN as well. Other conditions like Addison's disease or urinary tract obstruction also belong on the list. That's why high BUN is never treated as a standalone diagnosis. Doctors compare it with creatinine, hydration status, diet, and symptoms to find the real source. Sometimes the fix is as simple as proper hydration. Other times it involves reducing protein intake, adjusting medications, or managing underlying issues like diabetes, blood pressure, or heart failure. Number 5. Presence of albumin in urine, albuminuria. Imagine a security system that's supposed to let trash out, but never valuables. And then one day, valuables start slipping through. That's albuminuria in simple terms. Albumin is a large, essential protein that belongs in your bloodstream. Healthy kidneys are built to filter waste while keeping proteins like albumin locked inside. When albumin shows up in urine, it means the kidney's filtering barrier has been damaged enough to leak. That leak can be tiny at first, but it's meaningful. This is one of the earliest and most sensitive warning signs of kidney damage. Even small amounts, known as microalbuminuria, can appear long before creatinine rises or eGFR drops. That's why doctors pay close attention to it, especially in people with diabetes or high blood pressure. High blood sugar slowly scars the kidney's filters, while hypertension damages the small blood vessels that support them. Over time, those stresses weaken the barrier and albumin escapes. Albuminuria isn't only about kidneys either. Its presence signals widespread blood vessel damage, which is why it's strongly linked to a higher risk of heart attack, stroke, and heart failure. In other words, it reflects vascular health across the entire body, not just the kidneys. Temporary spikes can happen with infections, dehydration, fever, or intense exercise. But persistent albumin in urine is the real concern. Doctors usually measure this using urine testing, often paired with the albumin to creatinine ratio to improve accuracy. Management focuses on slowing further damage. Blood pressure control is critical, especially with medications like ACE inhibitors or ARBs. Diet changes, such as reducing sodium and managing protein intake, help reduce strain. For diabetics, tight blood sugar control is essential. And now let's talk about number 4, high urine albumin to creatinine ratio, UACR. What if I told you there's a way to catch kidney trouble early without waiting for symptoms, scans, or dramatic lab spikes? That's exactly what the UACR test does. Instead of looking at albumin alone, it compares albumin to creatinine in a single urine sample. Why that matters is simple. Urine concentration changes all day, depending on hydration. By anchoring albumin to creatinine, UACR gives a reliable picture of whether protein is leaking through damaged kidney filters. Under healthy conditions, albumin stays in the bloodstream where it belongs. When kidney filters weaken, albumin slips into the urine, A UACR below 30 mg/g is considered normal. Once results hit 30 mg/g or higher, that leakage is no longer accidental. It's classified as microalbuminuria and signals early kidney damage. Numbers between 30 and 300 suggest mild to moderate injury. Anything above 300 points is considered significant damage and, in some cases, nephrotic range disease. This test is especially important for people with diabetes or high blood pressure because both conditions quietly damage kidney filters long before pain or swelling appears. That's why doctors rarely act on a single UACR result. Temporary spikes can happen from dehydration, infection, fever, or heavy exercise. Repeat testing confirms whether the leak is persistent or just a short-term fluctuation. High UACR doesn't just predict kidney decline, it also forecasts cardiovascular risk. Persistent protein leakage reflects widespread blood vessel damage, which is why elevated UACR is linked to higher chances of heart attack and stroke. Clinicians use it to monitor disease progression, guide medication choices, and evaluate how well treatments are working. In short, UACR isn't about one bad number. It's about spotting damage early, tracking risk over time, and stepping in before kidney strain turns into permanent loss. Number 3. Elevated cystatin C levels. Just think about a marker that doesn't care how muscular you are, how much protein you eat, or whether you skipped leg day for the last decade. That's where cystatin C quietly earns its reputation. This protein is produced at a steady rate by almost every nucleated cell in the body, all the time. No lifestyle flexing, no muscle bias. Once it enters the bloodstream, healthy kidneys filter it out efficiently. The tubules then reabsorb and break it down, which is why almost none of it ever shows up in urine. When blood levels rise, it points directly to reduced filtering capacity. What makes cystatin C especially valuable is how closely it reflects true glomerular filtration rate. Elevated levels mean the kidneys aren't clearing it as they should, even if creatinine still looks normal. That's why it's often better at detecting early kidney decline, particularly in older adults, people with unusually high or low muscle mass, and patients with diabetes. Creatinine can be misleading in those groups. Cystatin C is far less influenced by age, sex, diet, or muscle bulk. Clinicians use cystatin C to confirm GFR when creatinine-based estimates are uncertain. It's also helpful for early monitoring of kidney disease and for adjusting doses of medications that rely on kidney clearance. In these situations, accuracy matters more than tradition. That said, cystatin C isn't immune to outside influences. Levels can rise with fever, inflammation, thyroid disorders, obesity, certain cancers, or specific medications. They may drop slightly with changes in hydration, time of day, or rapid weight loss. That's why results are always interpreted in context. Elevated cystatin C doesn't announce kidney failure. It signals a subtle loss of filtering efficiency, often earlier than other markers, giving doctors a clearer window to act before damage becomes obvious or irreversible. Number 2. Abnormal electrolyte levels. And here comes a signal the body doesn't whisper, it stutters. Electrolytes are tiny minerals, but they run massive systems. Potassium fires nerve signals. Sodium manages fluid balance. Calcium keeps muscles and the heart contracting in rhythm. Phosphorus supports bones and cellular energy. Healthy kidneys constantly fine-tune these levels, filtering excess out while returning what the body still needs. When kidneys lose that control, the balance slips fast. With kidney damage, filtration weakens. Potassium begins to accumulate, leading to hyperkalemia. At first, it may cause vague weakness or tingling. push further, and the heart rhythm becomes unstable, sometimes dangerously so. Phosphorus rises as well, a condition called hyperphosphatemia. Excess phosphate pulls calcium out of the blood, weakening bones and disrupting cardiovascular function. Sodium can swing in either direction, causing fluid retention, swelling, or dehydration. Calcium imbalance often follows, tied closely to vitamin D disruption and phosphate overload. These shifts don't happen randomly. As kidney function drops, often below about 30% in chronic kidney disease, the ability to excrete potassium and phosphate declines sharply. Hormonal systems also suffer. The kidneys help regulate hormones like aldosterone, which controls sodium and potassium balance. When that regulation fails, electrolytes drift even further from safe ranges. This is why abnormal electrolytes demand immediate medical attention. Doctors review medications first, since drugs like ACE inhibitors, potassium-sparing diuretics, or supplements can worsen imbalances. Diet changes often follow, limiting potassium, sodium, and phosphorus intake. Underlying conditions like diabetes and high blood pressure must be tightly controlled to slow further kidney damage. In advanced cases, dialysis becomes necessary to physically remove excess minerals. Electrolyte abnormalities aren't subtle warnings. There's evidence that the kidneys are struggling to maintain stability. When these numbers shift, the body isn't just out of balance, it's asking for intervention before nerves, muscles, and the heart pay the price. Number 1. Anemia, low hemoglobin, hematocrit. You may focus on cures when you're exhausted, breathless, or dizzy, but anemia tied to kidney disease usually starts long before anyone connects the dots. The kidneys do more than filter waste. They also produce a hormone called erythropoietin, or EPO. That hormone sends a clear instruction to the bone marrow: make red blood cells. When kidneys are damaged, that signal weakens. Fewer red blood cells are produced, oxygen delivery drops, and anemia slowly takes hold. This form of anemia isn't caused by bleeding or iron loss, which is why it often goes unnoticed at first. Blood tests begin showing falling hemoglobin or hematocrit levels, yet there's no blood in the stool, no heavy bleeding, no obvious explanation. That pattern is a hallmark of renal anemia. As oxygen levels fall, symptoms creep in. Fatigue that doesn't improve with rest, weakness, shortness of breath during simple activity, pale skin, dizziness, and reduced mental clarity. Quality of life quietly erodes. Diagnosis is straightforward. A routine blood test confirms anemia and helps evaluate kidney function at the same time. Doctors then look deeper to rule out iron deficiency and determine whether low EPO production is the root cause. Treatment focuses on the kidneys first, because without addressing that foundation, symptoms persist. Iron supplementation may be used if stores are low, but many patients require medications called erythropoiesis-stimulating agents, which replace the missing EPO signal and encourage red blood cell production. Managing renal anemia isn't just about feeling less tired. Untreated anemia strains the heart, worsens exercise tolerance, and accelerates complications in chronic kidney disease. That's why early recognition matters. If symptoms align and blood counts drop without clear iron loss, the kidneys often hold the answer. Reliable guidance and detailed resources are available through organizations like the National Institute of Diabetes and Digestive and Kidney Diseases. But the first step is recognizing anemia as a kidney warning, not a standalone problem to ignore. So that's all for today. If you found this video informative, then don't forget to like, subscribe, and share this video. Thanks for watching and hanging with us.